Hi, very good evening. So again after a long time seeing you live. So today we shall have a discussion on few important points, right? So self-assessment questions. So I'll be asking you a few questions and we shall have discussion among those questions, right? And a very good evening all of you. Hi Srish, Vineet, Shilpa. Hi Disha. Hi Sirisha, Preeti, Dhanalakshmi, Prithvi, Megha, Sishank, Nidhi. Seeing you after a long time. Yes, hi Priya, very good evening. Hi Chandana, hello. Hi Jana, Anu. Yes, hi Preeti, Shivaranjani, Bernice, hi, a very good evening. Hi Regina. Right, so we'll start off with our first question. You have any queries apart from what we have been discussing, you can drop them to proudtobedindustry@gmail.com, right? So first we'll start with some memory-based topics like the values of various serum constituents. Okay, what is the normal or the typical normal range of potassium in blood? So we have various factors like various constituents with different levels, right? We even have on PDF in our classes where we have shared the normal range of various constituents. It can be either electrolytes, enzymes, proteins, etc., right? So we'll have a discussion of these memory-based topics first and then we'll go into the details of these topics. So what would be the normal potassium level in blood? Or in plasma, what is the normal potassium concentration in plasma? Yes, hi Priya Malik, hi Nandini, hi Deepthi, a very good evening. Yes, good. Normal potassium concentration in plasma is 3.5 to 5.5 and the units are very important. Good. It's milliequivalents per liter. So normal plasma potassium levels, isn't it? So when you see hypokalemia, so in which situations or when the concentration falls below a threshold of 3.5, we say this hypokalemia. So what would be the clinical manifestations of hypokalemia? Yes, it is between 3.5 to 5.5. The normal plasma range of your potassium is 3.5 to 5.5 milliequivalents per liter. So we see hypokalemia when the levels fall below 3.5. So what would be the clinical manifestations of hypokalemia? Very good, Regina. There can be fatigue, there can be myalgia, cramping, as Regina has rightly said, and also muscular weakness, isn't it? Yeah. So manifestations of hypokalemia. So there can be fatigue, tiredness, muscular weakness, and in extreme cases, in cases of severe hypokalemia, even a respiratory arrest can also be seen because of the fatigue of the muscles involved in respiration, isn't it? So hypoventilation, there can be hypoventilation. Severe hypokalemia can also lead to hypoventilation because of involvement of respiratory muscles, and eventually there can be complete paralysis, isn't it? So hypokalemia can lead to fatigue, muscle weakness, there can be myalgia, and because of this muscle weakness, there can be even, in severe cases, severe cases of hypokalemia, there can be respiratory arrest also, isn't it? So the question now is, deficiency of potassium can lead to dry and cold skin, lethargy, muscle weakness, muscle excitability. So deficiency of potassium leads to which of the following options? Dry and cold skin, lethargy, muscle weakness, and muscle excitability. So obviously it is muscle weakness, and this muscle weakness, fatigue or myalgia is mainly seen because of lowered or decreased membrane potential. That is, the membrane potential becomes even more negative, right? So this is in brief regarding the levels of potassium in blood and also the consequences of hypokalemia. And when do you call the condition as hypokalemia, right? So based on the levels in plasma. I hope it's clear. So memory based, make a note of them and revise them repeatedly. Now let's move on to a few other memory based questions. Like for example, if I ask you what is the normal level of plasma proteins like albumin in blood, what would be the normal plasma concentration of albumin? As you know, albumin is one of the major constituents, major proteins, major constituents which is present in the blood among all the given proteins. It occupies more than 60%, or it constitutes around 60% of all the proteins in blood. And plasma protein is very much essential to maintain osmolarity and also has a huge role to play in drug binding, drug affinity, etc. Right? So what is the concentration or what is the amount of albumin that's present in blood? Yeah, in grams per deciliter. Do you really remember these values, or are you searching them, or are you trying to give me the values? It's very impressive to see the exact value which you have been giving. Dhanlakshmi, Regina, Sishank, Prashanthi, Niharika. So do you have that in your mind, the values and all? If yes, that's fantastic. So the normal albumin levels in blood . Okay, you remember them because they are the same. Good. It's 3.5 to 5.5 grams per deciliter. Please note that these are in grams. Oh, come on, Divya. Okay. In that case, what is the normal ratio of albumin and globulin? So when you compare albumin and globulin proportions, albumin by A by G ratio. So what is the normal A by G ratio? Albumin by globulin. When you compare albumin and globulin, obviously albumin is higher in concentration, isn't it? So what is the normal A-G ratio? And Divya, I must say I have good students like you all. Yes, ratio you can express that in a simplest number possible, isn't it? Deepti says 4:1. Okay. Yes, the normal ratio is 1.2:1 to maximum of 2:1. Okay. Good. And what is the levels of bilirubin in your blood? And don't worry, Preeti. You at least know now, right? You at least know the values now. So what is the normal level of bilirubin in blood? Three to 4 would be classified or categorized as mild form of jaundice. It's usually less than 0.5 to 1.5, isn't it? Less than 1 milligram per deciliter. Okay, now what would be the total protein quantification? What would be the total amount of protein in blood? Total amount of protein in blood. Yes, bilirubin levels in milligram per deciliter, less than 1 milligram per deciliter. What would be the protein content in blood in grams per deciliter? Good, Shilpa. Yes, Nidhi. Fantastic. Okay. We'll stop these values here. We'll proceed with the next set of questions, right? Yeah. Now, what does the term CPR mean? In emergency, what does the term CPR mean? Angel, you're typing faster than the speed of light. And Nikita, Prashanti, Shivaranjani, Tabish, Divya, Prithvi. Wonderful. No one has used shortcuts. In fact, that's really surprising. Dhanlakshmi, Preeti, Shilpa, Niharika, Dhanapriya, Sishank, Preeti. Hi Kedar, Srish. Super. Okay, so CPR is what, Divya? See, your statement is an offensive. I mean, you say today's generation types are fast. You think I belong to a previous generation? Okay. CPR stands for cardiopulmonary resuscitation, right? So when performing CPR, so what is the first thing we do? You have the protocol, right? So what is the first thing you do when, in case of emergency, when you're when you're providing basic life support while performing CPR? Obviously, the term itself describes the fact that chest, you have this cardiopulmonary resuscitation. You're trying to resuscitate the blood supply back again, right? In case of basic life support, yes, we have this ABC protocol, but as per the 2010 AHA's guidelines, American Heart Association guidelines, C should be performed first. Okay, you can just Google out, you'll get the PDF of AHA, American Heart Association guidelines. So now it is circulation first, followed by airway breathing and definitive care, right? Now, the question is, when performing CPR, so when you perform chest compressions, where should you apply pressure on chest? What is the landmark? Good. Yes. It has to be 2 inch below the sternum, lower 1/3 of sternum, beneath sternum. What you said is right. So it has to be in the mid-sternum area, approximately 1.5 to 2 inches, that is 2.5 to 4 centimeters above the xiphoid process, the lower part of your sternum. Xiphoid process, it's nothing but your cartilaginous process of the lower sternum, right? So mid-sternum, 1.5 to 2 inches above the lower part of the sternum, that is your xiphoid part, xiphoid process, right, which is a cartilaginous process. Good. So in cardiopulmonary resuscitation, chest compression is done on upper part of sternum, on the jiffy sternum, on the middle of lower part of sternum, on the left side of the chest. I'll repeat the options again. In CPR, chest compression is done on upper part of sternum, on jiffy sternum, on middle part of on the middle of lower part of the sternum, on the middle of lower part of sternum, on the left side of the chest. So obviously it is option C, on the middle of the lower part of the sternum, right? Yeah, among the given option. It's not on the xiphoid process, it's 1.5 to 2 inches above the xiphoid process. Fantastic. Now let's move on to the next question. Which organisms, I mean, I'm sure you're all aware of this antibiotic prophylaxis regimens for infective endocarditis, right? You might have referred my previous video on the same. Now the question is, which organisms, which microorganisms are implicated in infective endocarditis, or the organism that mainly causes infective endocarditis is what? You want me to give options? Okay, let's assume, Angel, you don't have options. Yes, Streptococcus mutans. Streptococcus sanguis. Streptococcus mitis. How come all answer before completion of question? The question is complete, Brijesh. I've asked the organisms which are implicated in infective endocarditis. So all these come under viridans group of streptococci. And also we have added around more than 10. We had around 10, I guess, image-based questions pertaining to these nutrient broths, pertaining to the culture characteristics of various microorganisms in our Grand Test 3. The test is already updated to your test series website. It will be live tonight by 12 AM, and you can go through a lot many image-based questions, and I'm sure you're going to enjoy the question paper. So we'll be covering various microorganisms, their culture characteristics as well. So all this virulence group of Streptococcus mutans, sanguis, mitis, etc. These are implicated in infective endocarditis in more than 55% of the cases. As per many studies, many values do exist, right? And you know what? These virulent streptococci are normal inhabitants of your oral and oropharyngeal area, right? They are normal inhabitants. Yes, the organism, let me ask you the question with options now. The organism that most commonly causes infective endocarditis is Streptococcus mitis, Staphylococcus aureus, Streptococcus pyogenes, Streptococcus viridans. So which option would you choose? Because different articles, different sources give different values. Yes, what is infective endocarditis? Okay, infective endocarditis, also called as bacterial endocarditis. It's infection caused by bacteria that enter the bloodstream and settle in the heartland. Usually these bacteria are normal common cells. As I said, these streptoviridans streptococcus are normally present in oral cavity and your pharynx, but once they enter bloodstream, they have the potential to line up and to colonize in different areas altogether. For example, heart valves or blood vessels, etc. Right? So that's in brief in infective endocarditis. Right? We have different causes for infective endocarditis. And when you're proceeding with any treatment procedure, it's always advisable to refer the patient to his or her respective cardiologist and give prophylaxis necessary to that patient. In one study which I referred, it's mentioned that more than 55% of the cases it's caused by, it has this virulent group of streptococci as the etiological agents. Okay, just give me 2 minutes. I'm seeing if I can give you more information regarding the bacterial etiology. Yes, different articles are giving different values. According to one article, it's 21 to 43% of the cases caused by anaerobic and microaerophilic streptococci. As per my references, it is 55% of the cases. So mostly it is viridans group of streptococci, right? And also propionibacterium, bacteroids, clostridium. Fine. Yes, prophylaxis, we have a video as such, right? You can refer that for more information. Antibiotic prophylaxis regimens. Now, another important topic. In case of MI, myocardial infection, myocardial infarction, MI, the first enzyme to rise in the blood, is it creatine kinase, lactate dehydrogenase, aspartate transaminase or SGOT, option D, amylase. So which of the following enzymes is the first to rise in case of myocardial infarction? Ischemia leading to infarction, isn't it? So in case of MI, what are the various diagnostic markers? Okay, so just make a note of these diagnostic markers. I'll be writing down here. So DM stands for diagnostic markers. Time of peak elevation, and characteristics. Myoglobin, time of peak elevation is 4 to 6 hours. Cardiac troponin I. So you can just make a note along with me, right? So that you will not be wasting your time. Cardiac troponin I. (12 to 24 hours). Cardiac troponin T. 18 to 36 hours. Creatine phosphokinase or creatine kinase. Creatine phosphokinase, also called as MB, 20 to 30 hours. Lactate dehydrogenase, 2 to 3 days or 48 to 72 hours. And aspartate transaminase, also called as SGOT. (30 to 48 hours). Okay, you can just make a note of these values. This is very, very important. So various diagnostic markers for evaluation of acute myocardial infarction. So these are diagnostic markers for myocardial infarction. As you can see, myoglobin is the first to rise, 4 to 6 hours. Cardiac troponin I, 12 to 24 hours. Cardiac troponin 2, 18 to 36 hours. Creatine kinase, 20 to 30 hours. LDH 48 to 70 hours, aspartate transaminase 30 to 48 hours. Now, the question is, among these enzymes, few are cardiac specific, whereas few are not specific to heart. So, myoglobin. So, in the question she asked, these three are present: creatine kinase, LDH, and aspartate transaminase. So, myoglobin is not cardiac specific. Okay, myoglobin is not cardiac specific. Cardiac troponin I is an early marker and cardiac specific. Cardiac troponin T is relatively early marker and cardiac specific. However, it's also elevated in other degenerative diseases. Creatine kinase takes 20 to 30 hours in order to see the peak elevation. It is cardiac specific and early marker. Creatine kinase. Lactate dehydrogenase is relatively a late marker but cardiac specific. Aspartate transaminase, it is not cardiac specific. So let me just mention here itself. So into denotes not cardiac specific. The stick mark denotes cardiac specificity. Okay, so these are various diagnostic markers for acute myocardial infarction. Please make a note. Anyways, I'll be sharing the picture of this of the same notes in your WhatsApp update group and also Google group, right? Yeah. So now coming to the question again, in myocardial infarction, the first enzyme to rise is creatine kinase, lactate dehydrogenase, SGOT, and amylase. SGOT is serum glutamic oxaloacetic transaminase or simply aspartate transaminase. Yes, it is creatine kinase. Good. Creatine phosphokinase, creatine kinase. Option C. Okay. Finally, what is cardiac tamponade? I'm sorry, our WhatsApp group is saturated for now. We'll have all the members added to our Google group, right? So that the advantage of Google group is we can enroll more members, and also the moment we post something on the group, you'll be getting an automatic, an auto-generated mail also, right? So you'll be getting a message in your group as well as you'll be getting a mail intimation as well. Okay, just send us a mail, we'll add you to the group. So what is cardiac tamponade? Yes, TAMPONADE. I'll write down here. Cardiac tamponade. Yes, fluid accumulation in the pericardium, thereby restricting the movement of heart, isn't it? Accumulation of fluid in pericardium and resulting in compression of heart is a cardiac tamponade. Now, which of the following is indicative of cardiac tamponade? Wide pulse pressure, Pulsus Paradoxus, Kussmaul sign, forceful left ventricular apex beat. Which of the following is indicative of cardiac tamponade? Wide pulse pressure, Pulsus Paradoxus, Kussmaul sign, forceful left ventricular apex beat. Kussmaul sign is nothing but rise in jugular venous pressure on inspiration because of restrictive movements or limited right ventricular filling. We have discussed in detail jugular venous pulse or pressure in our E-classes. You can refer that for more information. Kussmaul sign is nothing but rise in jugular venous pressure on inspiration because of limited right ventricular filling. What is Pulsus Paradoxus? Kussmaul's breathing is nothing but deep, labored, patterned breathing, which is seen in case of metabolic acidosis, right? Yes, we have Kussmaul's breathing as well. Kussmaul's sign is rise in JVP on inspiration because of restrictive or limited right ventricular filling. Kussmaul breathing is deep, labored breathing, as in case of your metabolic acidosis, with an attempt to eliminate more amount of carbon dioxide, isn't it? Then what is Pulsus Paradoxus? What is a paradox? Good. So Pulsus Paradoxus is nothing but abnormal decrease in the stroke volume, drop in systolic blood pressure, as Tabish has rightly said, more than 10 mmHg, and pulse wave amplitude decreasing during inspiration. So Pulsus Paradoxus is nothing but abnormally large decrease in stroke volume, systolic blood pressure, and also pulse wave amplitude during inspiration, and the drop in systolic blood pressure has to be greater than 10 mmHg. Paradox is nothing but something which happens in contrary, isn't it? Yes. Don't worry about these complex names, just simplify it. Cardiac tamponade is nothing but restrictive forces acting on your heart because of accumulation of fluid in the pericardium. This cardiac tamponade can lead to narrow pulse pressure, Pulsus Paradoxus, and also hypotension. Pulsus Paradoxus is seen in 95% of the patients with cardiac tamponade, and Pulsus Paradoxus is nothing but abnormal decrease in stroke volume as well as systolic blood pressure and pulse wave amplitude during inspiration. Right? Good. Angie? Yeah. So it's already 40 minutes. We'll stop it here. I'm really frankly missing these live sessions a lot, but because of some work pressure or whatever I should say, I'm unable to come live more frequently, but I promise you we're going to have more live sessions and we're going to cover more information in as simplified manner as possible, and all these coming 15-20 days will focus mostly on memory based topics, values, and as many MCQs as possible, and this is my promise, right? So we'll do it from next week, as many as possible. So till this Sunday or Monday, as I said previously, I'll be occupied with some work, but from next week onwards, that is approximately from the third week, we'll have more time allotted to our e-classes, test series, and most importantly, we'll focus more on live sessions also. We'll try to have daily interaction, okay? Okay, I just wanted to explain that first, but somehow I forgot. So SAQ, so Regina, thank you for asking me. What does SAQ mean? SAQ is nothing but self-assessment questions. We can call it a short answer questions, but in my mind it's more of self-assessment questions, because I'm trying to obtain or assess your performance based on the questions which are being picked up in the session, right? So self-assessment questions. Also you can call it a short answer, which is altogether a different set of questions. Yes, Nidhi. So acute bacterial endocarditis is caused by, yes, Staph aureus. Subacute by Streptococcus. Yes, you can refer oral medicine. Obviously, you'll get more information on that. Yeah, thank you so much, Nidhi, for adding up. Obviously, Bernice is a very sharp student, right? She knows everything, right, you know. Yes. Okay, we'll stay in touch through WhatsApp and through mails. And if you have any questions, drop them at proudtobedentist@gmail.com. And as I have made one video yesterday on 20 days before NEET, there is nothing to fear, there is nothing to get depressed. Do as much as you can and never feel stressed out. Take breaks if necessary. But if you think that you're feeling depressed, or if you think you're having more and more fear, it means you're only decreasing the quality of your preparation, right? So it's counterproductive. So try to use your time to maximum extent possible, and most importantly, believe in yourself. You're going to do very well, right? So you have any questions or you need any guidance, drop a mail. I'm just a mail away from you, right? Wish you all the best. Love you all, take care. And she's not my assistant. Yes, drop a mail at proudtobedentist@gmail.com, right? I'll send you all the details. And thank you, Nidhi, for adding up few important points. So whenever you come to our live session, you always add up something, thereby helping everyone who is participating in this live session. Glad to have you, and glad to have each one of you for making this live session more lively and lovely, okay? Yeah, see you again next week, right? Yeah, bye, take care, love you.